Hi everyone, my name is Jessie Lynch and I'm an emergency medicine SPR working in University Hospital Waterford Emergency Department. I'm presenting on our development of an in situ simulation based teaching programme in our emergency department. So, why did we start the programme? We noticed in July that we had a large cohort of very junior team members, in particular quite a number of SHOs who had never worked in an emergency department before, and a few who had just completed their internships. There were also many team members who had never worked in Waterford before. We felt that a simulation-based teaching program would be beneficial in many ways to help more junior members of the team develop a systematic approach to assessing and managing a patient in ED, to orientate EM NCHDs to the department, the layout of a resuscitation room, available equipment in the department, the available resources and how to request them. For example, things like where the antidotes press is in the emergency department and what's kept in the press versus what needs to be requested from the pharmacy and other things like this. We also have an excellent ED handbook, which is available on all of the computers in the department and linked a number of the SIMs to new guidelines protocols, which were being published on the handbook to make people aware of their presence and what a useful resource they are, particularly in high stress situations. We felt that a simulation-based teaching program would also help EMNCHDs develop team dynamics, communication and human factor skills. In particular, working alongside emergency nurses in a resuscitation scenario and working in parallel with other specialties. And we put emphasis on the shared mental model and closed loop communication. The simulation-based teaching program also allows us to expose team members to rarer high-risk clinical presentations and how to manage them. Simulation allows the participants to make mistakes in a safe environment with no repercussions for patients and to learn through exposure. We also utilise the programme to practice procedural skills such as rapid sequence induction, use of the RSI checklist, ensuring a failed airway plan is in place, and other things like this. Another pretty big benefit of the programme is stress inoculation. We put emphasis on the 0 point survey, which was developed by Cliff Reid, an emergency physician in Australia, which follows the acronym STEP UP, Self, Team, Environment, Patient, Update and Priorities, but puts a lot of emphasis on preparing yourself for a resuscitation scenario. So how did we put the programme in place? The programme runs in parallel with our weekly didactic teaching sessions, although we're now also moving towards making these less didactic and more interactive to facilitate engagement and an improved learning experience. Our simulation scenarios are written by an EM SPR and consultant, and the simulation is run every Monday, dependent on staffing. We have changed the time of the simulation a couple of times in order to find a time that best suits both NCHDs and nursing staff. It currently runs at 11 a.m. Reminders are sent out by email, and there's posters placed around the department to remind people of the simulation taking place. The simulation itself takes place in resus, and it runs for approximately 15 minutes with a 10-minute debrief. There is one SHO and one registrar assigned each week on the teaching rota, and generally, unless it's a very complex scenario, the SHO commences the scenario and then requests senior help as necessary. And we emphasise that they should request senior help at a time within the simulation where they would in real life. Then afterwards, learning points from each simulation and debrief are disseminated to the group. So these are just examples of some of the resources we use when putting together the simulations. So EM Sim Cases, the Internet Book of Critical Care, which is produced by IMCRIT, the East Midlands Emergency Medicine Educational Media, or EM3, Cork's very own EMED, Life in the Fast Lane, and OrChem Learning. These are some of our guidelines that we have designed simulations around, including life-threatening asthma, local anaesthetic systemic toxicity, and acute heart failure or flash pulmonary edema. And these are the fabulous posters that Dr. Moriarty, one of the emergency medicine consultants, designs. They're placed around the department to remind people about the simulation sessions. This is just an example of our teaching schedule. You can see in the kind of turquoise teal colour where the simulation sessions are, with certain people assigned to participate each week. Simulation sessions are mandatory for the assigned NCHDs, and everyone else is encouraged to attend. As you can see over on the right of the screenshot, there are links to learning points which are uploaded after each simulation and contain the most important learning outcomes from each scenario. And this is just an example of the learning points. This one is from a trauma simulation based around a farming accident. In terms of equipment, we have a relatively low to moderate fidelity mannequin. There's also an infant mannequin which we borrow from pediatrics when we're running pediatric scenarios. We previously had a small trolley with simulation equipment, which has now become a large portable cabinet of simulation equipment. We keep single-use equipment such as ET tubes, laryngoscopes, etc., and reuse it for simulation. And we make simulated drugs with labeled syringes and sodium chloride. And those are our fabulous blood products there in the middle. We use the Simple app, which is a free app available for Apple and Android, and display the vital signs on a tablet. So, scenarios we've run so far: inferior STEMI with bradyarrhythmia, neonatal sepsis, eclampsia, severe COPD exacerbation, ectopic pregnancy, major trauma, acute pulmonary edema, ruptured AAA, tricyclic antidepressant overdose, myasthenic crisis, thyroid storm, massive epistaxis, life-threatening asthma, hypokalemic cardiac arrest, local anesthetic systemic toxicity, burns with cyanide poisoning, laryngospasm in pediatric ketamine station, pediatric hyponatremia and seizure, and bronchiolitis requiring high flow nasal oxygen. So these are just some photos of our team participating in the simulations. I thought it would be nice to include some of them. So in terms of feedback, we sent out a survey using Google Forms to the NCHDs and any nursing staff that had been involved in the simulations. We took note at each simulation who had been involved. We got 22 responses, which was a relatively high response rate when you take into consideration the level of staffing in our department and the fact that not all nursing staff had been involved in the scenarios. The feedback was generally very good. Respondents felt the simulation scenarios and debriefs were in appropriate length, that the complexity of the cases was at an appropriate level, and that the content of the debrief was appropriate and added to their learning. These are just some of the comments of what people liked about the simulations. I hope everyone is able to read them on the screen, in case you can't. So, working as an MDT, practical elements such as building confidence for situations we regularly have, highlighting simple issues that could be easily rectified in a real situation. Salient information and very useful for those who lack experience in paediatrics. Relevant content, information on how to use available resources, and excellent debrief with helpful information, such as the Misfits mnemonic that was for a neonatal simulation. Excellent way to come together as a team and work through sample cases, a great way to learn from others. Practical and related to real acute emergency presentations, which helped broaden my knowledge and strengthen my skills. And practical and informative, and I think it will really help me to effectively evaluate and manage patients with similar presentations in the future. So some really, really good feedback there. In terms of things that could potentially be improved, some people felt a little bit uncomfortable having an audience, but acknowledged that the audience should be there so that everybody has the opportunity to learn as much as possible. They also requested a few extra team members to call on, but again, acknowledged that that would probably not be entirely realistic. Timing was not ideal during nursing break periods, and again, this is something we've worked on throughout the duration. Somebody asked if the vitals could be displayed on a bigger screen, which would be more beneficial for the attendees standing at a distance. Not something we've managed to rectify just yet, but certainly something we've taken into consideration. And again, somebody else said practical interventions were summarised, and it would be a good idea to demonstrate it at the end of the simulation. Such as chest drain insertion, pericardiocentesis, other procedures, which would help all junior doctors to become more confident about performing these procedures. And that leads me on to our plans going forward. So we want to further embed sim culture within the department, within our own EM nursing and medical staff, and then to involve other specialties and disciplines such as radiography, radiology, critical care, blood transfusion scientists, pediatrics, etc. We're planning to move to fortnightly simulation to avoid sim fatigue, alternating with practical skills on alternate weeks, such as chest drain insertion, ultrasound, airway skills, nerve block, and ultrasound guided IV access. We're going to continue to update and add to our current bank of scenarios. Ones we've planned in the near future include neurogenic shock, cardiac arrest in pregnancy, varicose upper GI bleed, hypertensive emergency into digoxin toxicity. So we're working on developing those at the moment. In terms of knowledge translation, we are migrating the learning points from the Google Sheets that I showed you earlier to a new emergency medicine mobile app that we're going to be using. And we're going to include the sim rota and the scenario pre-brief on the app, and this should allow everybody easier access to all the resources. We're going to continue to collect feedback weekly to ensure learner needs are being met. So that's everything. If anyone is considering starting up an in-situ simulation program in their department, I would strongly encourage it. It's an excellent educational format. Our group seemed to have gotten an awful lot out of it, and it was also a good bit of crack. Thank you so much for the opportunity to present on our simulation program, and I hope everyone is enjoying the symposium. I'm happy to take any questions.